Hey there, nursing students. Welcome to this high-yield explainer covering chapters 21 and 22. I know you all have a ton on your plates right now, so this review is designed specifically to help you efficiently crush your upcoming Week 5 quiz on older adult care. We're going to completely bypass the fluff and focus entirely on the most critical clinical cues, the fundamental physiological changes of aging, and the exact nursing actions you need to know. All right, let's quickly run through our systems check agenda for today. We've got osteoporosis, risks and remedies, then arthritis, breaking down types. Next is cardiovascular changes in aging, followed by managing heart disease. Then we'll hit respiratory risks and pneumonia, and wrap it all up with clinical judgment in action. But hey, before we get totally bogged down in all the heavy pathology, let's just set a really positive, focused tone for our study session. As Dr. Seuss so brilliantly put it, the more that you read, the more things you will know. The more that you learn, the more places you'll go. Remember, your dedication to understanding this material isn't just about passing a quiz, although we definitely want that. It's really about you becoming an incredibly observant, top-tier nurse. So let's get learning.
First up on the docket, osteoporosis, risks and remedies.
It's honestly wild to look at the stark physical degradation that happens inside the body here. Notice that dense, healthy matrix of the normal bone on the left. It's robust, right? It's built to actually support the body's weight. But then compare that to the fragile, porous, almost web-like structure of the osteoporotic bone on the right. When you see it laid out like this, you instantly understand why osteoporosis poses such massive risk for fractures and mobility issues in our older adult patients. The structural integrity is just completely compromised. Now, what's really fascinating and kind of scary is how that internal microscopic bone loss actually shows up on the outside over time. Look at this progression from age 40 to 60 and then 70. You can clearly see those postural cues, right? The kyphosis, that stooped posture, and the really noticeable height loss. When you're assessing a patient, these visual cues are your immediate red flags that osteoporotic changes are actively happening in their spine. So, what's our game plan as nurses? For your quiz, you absolutely have to know your primary nursing actions here. First, you prioritize fall precautions, because as we just saw, those bones are incredibly fragile. You also need to highly encourage weight-bearing and muscle-building exercises. This is a big one, because placing mechanical stress on the bones actually stimulates them to maintain their density. Add in improving their nutrition and really pushing for smoking cessation, and you've got a solid, comprehensive preventative care plan. When we get into nutrition and pharmacologic therapies, you need to burn this vital number in your brain, 1,000. 1,000 milligrams is the standard recommended dietary allowance for calcium. Now, self-correction here. Keep in mind that for postmenopausal females, that target actually bumps up to between 1,200 and 1,500 milligrams, just to counteract the rapid bone loss from hormonal changes. But 1,000 is your solid baseline to remember. You can't just hand out calcium and call it a day, right? To actually absorb that calcium into the body, it needs a helper, vitamin D. The standard recommendation is 600 international units, but this is key. It increases to 800 IU for patients who are 70 and older. You are going to frequently see these prescribed together as combination supplements to maximize bone mass and stop that bone turnover. Moving right along to section 2, arthritis, breaking down types. Okay, quizzes absolutely love to test this. You have to clearly contrast osteoarthritis against rheumatoid arthritis. Think of osteoarthritis as a degenerative disease, your classic wear and tear. It's often asymmetric, so it might just be in one heavily used knee, and the big hallmark sign is morning stiffness that lasts for less than 30 minutes. On the flip side, rheumatoid arthritis is a systemic autoimmune disease. It's characterized by symmetry, meaning it hits both hands or both wrists at the same time, and that morning stiffness is severe, lasting way longer than 30 minutes. Keep those two profiles totally separate in your mind. Then there's gout, which is another really common inflammatory arthritis, but this one is caused by the buildup of uric acid crystals. The key nursing action here is all about dietary education to stop those acute attacks before they start. Your patients must avoid high purine foods. That means organ meats, red meats, and specific seafoods like anchovies and shellfish are a definite no-go. Instead, you want to guide them toward the good stuff: fruits, veggies, whole grains, and low-fat dairy. Let's shift gears now to section 3, cardiovascular changes in aging. Take a look at exactly why older adults are at such a profoundly higher risk for hypertension. Think of the blood vessels kind of like plumbing. On the left, we see age-induced arterial thickening. As we age, that natural elasticity drops, the vessel walls get thicker, and the lumen, the space inside, narrows. Because that space is tighter, peripheral vascular resistance shoots up. So what happens? The heart has to pump so much harder to force blood through those stiff, narrow pipes, and that directly causes the heart muscle to thicken up, like you see on the right. We call that left ventricular hypertrophy. Understanding those anatomical changes leads us right into Section 4, managing heart disease. Pay really close attention to these clinical cues for your exam. Hypertension is literally the most common chronic cardiovascular disease in older adults, and we usually catch it during routine screenings. We also see really high rates of atrial fibrillation, or AFib. The tricky thing about AFib is that it's typically totally asymptomatic, but it massively increases the risk for stroke, which means anticoagulation therapy is the absolute standard treatment. Finally, always be on the lookout for heart failure, which is just when that damaged, overworked heart muscle simply can't pump efficiently anymore. Okay, time for a quick mid-explainer pop quiz to test that clinical radar of yours. Imagine you're on the floor. An older woman is complaining of mild, localized back pain, along with some vague nausea and maybe a little heartburn. Based on what we know about cardiovascular disease and aging, what acute, life-threatening condition should you instantly suspect? Take a second to think about it. Yep, it's a myocardial infarction, a heart attack. You absolutely must remember that in women, and especially in older adults, that classic elephant sitting on my chest symptom is often completely missing. Their signs are much more likely to be mild, atypical, and super easy to confuse with just normal GI distress or minor muscle aches. Never, ever dismiss those vague symptoms in this population. Moving right along to Section 5, respiratory risks and pneumonia. A massive risk factor in this category is pneumonia. What you really need to take away here is that a lot of these cases can be proactively prevented just by staying on top of basic immunizations. Also recognize that the classic signs of infection can be easily confused or even entirely absent in frail elders. They might not mount a high fever at all or show an elevated white blood cell count. Because their immune response is blunted, a wait-and-see approach is incredibly dangerous. Prompt assessment and intervention are absolutely vital because frail elders can decompensate so rapidly. And finally, let's tie it all together in Section 6, Clinical Judgment in Action. This is essentially your roadmap for nursing actions. It should always follow this logical path. Step 1, obtain a thorough, comprehensive health history, so you actually know the patient's baseline. Step 2, carefully monitor all those interrelated vital signs, labs, and specific kidney, cardiac, and respiratory functions. And Step 3, collaborate. You work with an interdisciplinary team and the patient themselves to clearly define their goals of therapy and exactly what extent of treatment they want. Remember, we're treating the whole patient, not just a disease on a chart. Before we wrap up, I want to leave you with a little food for thought as you bridge into your next phase of studying. We've just reviewed how drastically the heart and lungs change with age, often completely masking typical symptoms. So based on that reality, how on earth do we effectively evaluate for neurological problems in our older adult patients? Think about how interconnected these systems are and how decreased oxygen from a struggling heart might actually just masquerade as dementia or acute confusion. Keep that in the back of your mind as you prep. Happy studying, and I know you're going to absolutely crush this quiz.